Hello, I'm Dr. Kim Sejin, moderator of the case discussion to share and find solution to difficult clinical cases. Hello. To resolve problems, we have three clinical masters, Professor Yang Seung-min, Dr. Son Young-hui, and Dr. Park Jong-hyun. Hello. If you're watching the Deno site, currently, please use the real-time chatting window on the right-hand side of the player to share your comments or ideas. Let's go to the question to discuss. Number 17, severe bone resorption, and it needs to be extracted. Number 16, was extracted a long time ago. Under the prosthesis, the bone height is very low. What should be the depth of placement? Should I place the implant deep and do the bone grafting to sinus only, or should I place it not so deep and do the sinus bone graft and vertical bone graft at the same time? That is the question. To place implants in the upper right posterior where the residual bone is deficient, what should be the placement depth and the bone graft approach? What's your take on this case? I deeply sympathize with the dentist who sent us the case as well as the patient. How the patient is chewing, prosthesis shape, the whole mouth is disastrous, and the treatment was delayed. So the important canines are destroyed and surrounding areas as well. So I really can't tell what should be approached first in the patient, and the dentist wants to focus on upper right treatment, and it is not easy there too. So throughout the mouth, do we need to approach the entire mouth or divide it into some sectors? We need to discuss that. If you look at the upper right segment, it's a dilemma. I've seen many such cases, and regrettably, we don't have the intraoral pictures. If we had them, we can tell whether gingival recession occurred or it is limited to bone loss. Treatment options can be different depending on that, and how we treat it can be different. But if I assume below the pontic, the bone is lost and soft tissue is covering the site to a certain degree, then the soft tissue should be maintained. If soft tissue exists, whether you do bone graft or socket preservation, something can be done. If that is not the case, a lot of things will be difficult. So if we assume soft tissue exists there, I can do some extraction and do some manipulation. I agree with Professor Yang 100%. If we just focus on quadrant 1, the sinus-related posterior region, based on the X-ray, the information that we can get is that both buccal and palatal bone is all lost and only sinus floor remains. At first, I couldn't quite understand the question raised by the dentist. Here, how to resolve the problem is important. It is not important on what level the implant should be placed. So my answer prepared for the question, if you look at this case, the staged approach would sufficiently resolve the situation. However, we need to tell the patient that it will take more than a year of treatment before we start the treatment. As Professor Yang said, whether there is remaining soft tissue or soft tissue recession has occurred, the difficulty of treatment would be different. Thank you, Dr. Park. Let's have a look at the analysis of the case. We don't have the CT images, so I don't know the accurate situation. As Professor Yang said, soft tissue is vaguely visible on the panorama. The soft tissue seems to be sufficient. 2 to 3 millimeters under the pontic, at least 2 millimeters of enough soft tissue. This is a composite bone defect. In this case, if you take a CT and if you observe after extraction, palatal bone is often found. Anyway, this is clearly horizontal and vertical bone defect. So according to the question raised by the dentist, the bone graft is not to be done on the top. The intention of the question would be the placement depth would be shallow and sinus bone graft followed by vertical and horizontal bone graft, if that is okay. What is important is that whatever the approach may be, that will work. If bone in the sinus can be created pretty well, that can be an option. The placement depth can be reduced. I'm not sure whether this is intra-bony defect or extra-bony defect. If it were extra-bony defect, whether we should augment vertically up to the top, I'm not sure. However, what is important is that the body top should be positioned at least 3 millimeters from the marginal gingival level. Let's look at a case which is a little bit easier. After extraction, bone was not formed. If we place the implant to the front based on the basal bone, it would be even worse. In such a case, I take a two-stage approach. Place an implant 5 months after bone graft. In this way, the second implant can be placed much easier with a little bit of a sinus lift. Final prosthesis was completed. This is a 1-year recall picture. The apical root picture is included. If the implants were placed a little bit deeper, maybe just by 0.5 millimeter, it would have been better. I hope there is no problem with that. It was finished with a minimal bone graft and minimal sinus bone graft as well. It has been maintained for a year now. Next case, which is similar. As long as the soft tissue is thick, I use staged approach because it makes surgery simple. At the palatal bone graft site, soft tissue is carved out to secure the space and bone graft is done and implant is placed. After waiting, this becomes a very general case. Final prosthesis is delivered. When the things are not good, I use complete supramargin approach. And after 3 years, the patient came back with a CT image compared to the initial state. I believe the status can be maintained. If you use the staged approach for the case under discussion, it can become a simple case, but I want to start after extracting all the teeth in the upper. This is a rather difficult case. Very little residual bone. If the placement was done more frontal position, however, the situation was not very easy and bone graft was done so the implant was not placed deep enough. After 3 months, in the second operation, the soft tissue was only 2 millimeters, so the implant was removed. And trusting the bone formed over 3 months, I placed the implant a little bit deeper. Without biologic width, implants can develop problems. When the residual bone is not enough in the sinus, if you place an implant on the bone level in a compromising way, problems may occur. After 3 or 4 months, I remove the implants and place a new one deeper. And this is the finalized picture. It's not really vertical, but the powder bone is filling the empty space in a cute way. Anyway, this type of treatment is necessary at the top, and it is finalized. The bone grafted part, top of the bone, is not in contact with the implant at all. Still, the bone graft in the gap helps to maintain the volume. The patient came complaining the mobile implant and said implant placement and bone graft were done right after extraction. The extraction socket preservation, just like the case that we are discussing now, in this patient, both horizontal and vertical bone loss seems to have occurred. But if you take CT, in many cases we find something like this. Happily and luckily in this patient, beautiful palatal bone still remains. So the difficulty of the case is considerably lowered than initially thought. And an implant is placed along the remaining palatal bone and bone graft in the empty space. After the bone graft, this is how the surgery was finished. And recently I did the second operation. At the time I opened it and checked. It was not a very hard bone, but something looking like bone was formed. For the patient, a final prosthesis will be delivered soon. My point is, on the panorama, vertical defect or complex defect may turn out to be a simple horizontal defect after extraction and waiting for some time. Also, if you look at carefully this patient, if we utilize the physiology of body, bone graft can be made very simple. 4 months after extraction, the bone was not formed sufficiently here. In this picture, it is not clear, but if you look at the CT, 360 degrees of the implants, 2 to 3 threads are all exposed. If you look at it carefully, the buccal bone and the palatal bone housing still remain. If you look at it carefully, this portion is an intra-bony defect. Palatal flap thinning, implant placement depth would be about this. Most importantly, if you are to graft a bone, dissection until the sound palatal bone is exposed is very important, so that that part will come in contact with the bone, and after the implant placement for bone graft, the space should be maintained. So it is important to thin the palatal flap where the soft tissue or granulation tissue has grown. The retention cyst portion is lifted a little bit with hydrolifting. The space obtained from the flap thinning is filled with bone graft material. Dissection is done up to the sound palatal bone, so the membrane is covering up to there. This is CT image after 4 months of extraction, right after implant placement and bone graft. I'm not sure about the long-term situation. However, this is what we did our best for the patient for the intra-bony defect. What do you think? I think you did a good job. I'm impressed. So if you use the physiology of body, bone graft and restoration can be done very well. I'm not very good at bone graft that goes against the physiology of body, such as vertical augmentation. My treatment protocol is to facilitate the body's healing process. This is the final CT image. So it was done just a few days ago, and I wish it goes well. And this is the last one. This is something different. On the right, soft tissue is thick enough, and there was a vertical height difference compared to the surrounding bone, so on the right, vertical augmentation is planned. On the left, the bone height is similar to adjacent bone, so I decided to do sinus bone graft only. You can see the placement is a little bit different. Let me magnify it. The right implant is not placed up to the basal bone level. This much, the implant threads are exposed. As the soft tissue was very thick, I carved out the soft tissue so that bone graft material can go in. That portion is carved out to maintain the space. In 2012, I used my favorite auto bone collector to harvest the bone from the extraction socket, and it is covered with bone and resorbable membrane. The approach was different, and the result after 5 years looks like it vertically went up. I didn't take CT, so I cannot say for sure, and I used different approach from right to left. Whatever the approach may be, I don't think the result would be that different. If I were to do it again on the right, I would place the implant on the basal bone and focus on sinus bone graft. In 2012, I was not good at sinus graft, so I just used the osteotome. In this case, now I can do the sinus better and would not try to do vertical augmentation on the right. How much should be the placement depth? I believe it doesn't really matter whatever the depth would be. At least 3 millimeters from the marginal gingiva for biologic width. Question number 2, should I place the implant deep with only sinus bone graft? If you do sinus bone graft, the bone will be better. The bone has vertical height difference compared to the surrounding bone, and the soft tissue is sufficient. Sinus bone graft and flap thinning can be done for vertical and horizontal bone graft. If not, sinus bone graft alone can work too. Summary: good vertical bone augmentation can bring dynamic advantage, but I'm not confident in doing it, so today I showed you the bone graft, which is kind of cute because it is minimal bone graft, relying on the physiology of a human body. I don't do vertical augmentation in an unfavorable environment, but I can confidently do the sinus bone graft. I don't do the surgery to make bone grow tall, but I can increase the heels of shoes so that you can get a little bit taller, as an analogy. Thank you. Next, Dr. Son Young-hui. Okay. That was impressive, Dr. Park. As you may have expected, I'm a little bit different. Surrounding the implant, sound body, sound mind. I would say good quality soft tissue will follow good quality bone. So I try to make good hard tissue as much as possible. This is my patient. Actually, it is a part of my dark history. I encountered all sorts of problems with the patient. All sorts of complications occurred, and the treatment was finished. Bilateral sinus graft was required. You can see the vertical defect less than the case under discussion right now, more severe in quadrant 2 than quadrant 1. This side, quadrant 2 is much more severe. So we did the surgery in quadrant 1. I did this sinus graft and bone graft. There was buccal bone defect, so bone graft is done. The reason I showed you this is that I do vertical augmentation, and I prefer to position the implant on the basal bone, and I prefer to do a lot of vertical augmentation. Even in the defective site, I do bone augmentation. At the time of surgery, the implant is not visible, so I do grafting all over. So I try to make hard tissue as much as possible for later modifications or other manipulations. In this patient, the sinus graft was done and onlay graft as well, bilaterally. If you look at the CT, the implant is in the middle of the graft material. So that's how I do the grafting. And during the second surgery, sometimes it is very difficult to locate the implant. How the grafted bone will turn out is very difficult to predict. It can be resorbed quite a lot or it doesn't turn into bone. So I try to graft as much as possible. The second surgery is finished. As you can see, the implant is in excessive bone, just like the case under discussion now. Mostly the defects are two-wall defects. It's not in the sinus side, it's crystal side. There are mesial and distal walls and no buccal or lingual walls. If it is perfect one-wall defect or no-wall defect, it would be very difficult. However, there's concave. That means wall exists at one side, so the grafting is done, getting the support from the remaining wall, and the prosthesis is delivered in quadrant 1 and 4. When I treat a patient, usually I treat one side first before moving on to the next. Now I move on to quadrant 2, sinus. As you can see, there is a concave part in the soft tissue as well as the hard tissue. So grafting is done like this. Sinus graft is done, and augmentation graft is excessively done for patients whose teeth were extracted due to periodontal reasons, or for patients like this, I do grafting and they tend to be remodeled rather excessively. As you can see, the implant is positioned near the basal bone. I don't go below the margin. It is equimargin. I'd like to place an implant near the basal bone. Personally, I don't trust the bone that I make. That way, I don't get frustrated. I expect that bone will not be formed very well. If I expect too much bone, sometimes I get disappointed. It is covered with the collagen membrane. As you can see, 1 is non-submerged and number 7 only is submerged. Now it is finished up to this. So I like to position the implant as close to the basal bone as much possible. Some people may think I place the implant too deep, but for internal submerged type of implants, the problem is much bigger if you do not place the implant deep enough. So I tend to place it a little bit deeper. In this patient, if you look at the x-ray, I did the second surgery today. The prosthesis is not delivered yet. So the answer to the placement depth, if possible, it should be placed near the basal bone as much as possible. To question number 2, do I need to place deeper so that I do the bone graft only in the sinus? Or should I place the implant not so deep and do sinus graft as well as the vertical bone graft at the same time? My answer to that question is we need to manage the vertical bone deficiency as well. So just doing one graft is not good enough when you plan the treatment. If you don't do as I explained, what happens? This is my case, and this is part of my dark history. Initial visit, The patient lives in Frankfurt abroad, and the patient comes to Korea from time to time for the treatment. The patient gives me international phone calls and gives me the date of treatment, and sometimes I get surprised because of the international call. The lower implants were placed in the UK. They were not placed by me. The patient came like this. You can see the history of our clinic's X-ray equipment. Quadrant 1 is problematic. I don't know why I placed like that. I must have been possessed. The sinus graft was done like that. I wouldn't do it like that if I do it again. As expected, over time, the quadrant 1 crestal bone loss occurred and pus came out like this abundantly. So the patient came from Frankfurt directly to me. The implants were removed, so was the prosthesis, and the pus panorama. Vertical bone loss is significant. I couldn't place implants as it was, and the patient came back to Korea, and with allogenic block bone, vertical bone augmentation graft was done. I should have created that. In this patient, sadly, the situation was almost like no wall or one wall, so block bone had to be used. Very expensive membrane covered the site, and it was healed like this. After that, this is the post-op panorama. This is right before implant placement, before and after. If you compare them, vertical bone loss is hardly there, but significant bone loss occurred. And I opened it again, and the 2 implants were placed and finished. Over time, prostheses were delivered. After the prosthesis delivery, panorama was taken, already bone loss started. Personally, I cannot really make vertical bone augmentation GBR. I hardly do the procedure these days. When you do the procedure with confidence, sometimes you encounter results like this. Of course, you can get the good result, but the possibility of getting a good result is pretty low. Let me explain the theory why I place implant very close to the basal bone. Let me ask a question. I also prefer to do huge volume bone graft, but soft tissue control to become very hard. Do you have any special tip for such cases? In the maxilla, periosteal releasing incision can be done. There are 2 ways to increase the soft tissue. Of course, there are connective tissue graft or pedicled flap rotation, but I'm not going to discuss about them here. So periosteal releasing incision and vertical releasing incision, those two vertical releasing incisions or 1 periosteal releasing incision can be used to increase the length by about 80%. When you do GBR, vertical releasing incision doesn't have to be used. But if you do not do the periosteal releasing incision, it's not good, so you need to keep that in mind. Thank you very much. Last but not least, Professor Yang Seung-min. Thank you for the comment from the 2 doctors. This is always difficult part. I agree with Dr. Sun. I do not know how much bone can grow. After the bone is grown, I place the implants according to the bone grown. I don't try to place the implants early. I expect to gain some volume of bone. I get what I expect often, but not always. Therefore, we need to get prepared for that. Dr. Son places the implant rather deep for such cases, and I do it a little bit differently. And let's have a look at what I do. The patient came to our hospital in 2004. Some of the x-rays are missing. Quadrant 2, when the patient came for the first time, quadrant 2 is not very good, and number 10, 11, and 21 have a lot of resorption due to ortho treatment. The patient lives in Japan, and he comes and goes for the treatment, and I was wondering what I need to do after the extraction. The vertical resorption would occur naturally, and how much horizontal resorption would occur. So intraoral situation is like this. Soft tissue, hard tissue are not available. As the patient is in Japan, I decided to give the treatment for all of them after the extraction. On the day of extraction, number 7 was luckily floating. If you look at the position of number 5, as you said, after the extraction, you can find the bone somewhere. There's a palatal wall and no wall on the buccal side. That's the lateral view. I thought the vertical and the lateral can be maintained, so I did the GBR in a standard way. With the extraction, the primary closure was obtained. As Dr. Son said, I used his approach, and the bone is healed. Patient lives in Japan. EPTFE or DPTFE membrane was used. The characteristics of the membrane is we don't know when it will erupt. So I removed it a little bit earlier, and the patient came back to Korea in about a year. And this is how the situation was. The vertical and horizontal situation was okay, so implants were placed. If you compare it to the initial status, I do not know where the bone would be grown. I cannot be confident. So I try to make as much bone as possible, and implants are placed according to the bone made. So if you look at from 2006 to 2020, the patient came to me this year too. For almost over 15 years, the positions look okay and well maintained. And I believe that should be approached with the concept of the aging of implants. On the X-ray, the bone is stable and has been maintained stably, which I'm thankful. So this case is for the question whether bone should be vertically raised or not. The answer is if bone can be made as much as possible in a natural way, the implants can be stably maintained for a long time. That's why I came up with this case. Another patient, I'm in a perio department, so there are many serious patients. At quadrant 2, the situation is very grave. Intraoral pictures, a lot of recession, and hopeless situation. So this is when extraction was made. On the palatal side, a lot of calculus. At that time, as Dr. Park said, a simple bone graft. In the past, we discussed about this problem. At that time, we used a lot of socket preservation. Number 4, and 6, socket preservation was done, but we didn't do it at one, and over time, bone did not grow there. If we put in something is made, as Dr. Park said. We take an easy approach. The socket preservation, which is not very challenging, can be done. And implants were placed, and according to the placement, GBR was done. If you look at where implants are placed, the bone is maintained very well after the extraction. According to the standard way, the second surgery was done and prosthesis. If soft tissue is not sufficient, the soft tissue part can be approached in a staged way, hard tissue as well. As I said before, we cannot be confident how much bone we will get. So if I do certain tissue manipulation, I try not to place the implants there. As mentioned before, the implant can be placed a little deeper. For placing an implant deep, as you can see here, I use US or SS implants. If you do not use TS implant, you need to have some way to deal with the situation. If you use TS, the problem would be solved. The form of the prosthesis is maintained for a long time. If you look at the direction, I try to make them symmetrical and it looks pretty good. If we go back to the case under discussion, the implant position, the most important thing is where soft tissue is. Depending on the volume of soft tissue, position of basal bone, and the amount of vertical bone that can be increased can be determined. I don't think I will place implants after extraction. We need to do something after the extraction. Basal bone, as mentioned before, or if we can do vertical augmentation, we need to do that. That is a safe way to place implants. As was mentioned before, not only that, I would treat other areas as well because the patient is in a grave situation. We need to take some actions quickly because the patient has been suffering for a long time and that needs to be considered. Thank you very much. 3 doctors gave us very good discussion. Let's go back to the case under discussion, and I asked the doctors to give us the final remarks based on what has been discussed. This case can be approached very easily or it can be a very challenging case. As I said before, try not to resolve everything all at once. You could divide the work to 2 to 3 segments, and the deficiency can be addressed one at a time. That will be an easier approach to treat this case. Dr. Son, as I said before, my style is not to do everything with placing an implant. I want to emphasize that a staged approach is better. Where to position the implants and how much graft needs to be done. Regarding that question, I would like to recommend to place the implant as close to basal bone as possible. Second, even where implants are not to be placed, personally, I prefer to plan the treatment to increase the hard tissue volume a little bit more. If the prognosis is not certain, that can make the case the most challenging one. For that, as Professor Yang said, after the remodeling, implants need to be placed. Lastly, Dr. Park Jong-hyun, let me talk about something different from the case under discussion. If the patient came to me, I would extract all the teeth and the maxilla if necessary and restore up to premolars before posterior region. First, I would provide something to chew and eat and a stable stop up to premolars. After that, I can take time in a staged approach. I don't think that will make a patient very unhappy. I would extract all the upper teeth and provide a complete denture, and I would restore up to premolars. In a staged approach, I would move to the posterior slowly. I don't like the approach that I treat quadrant 1 first, and while the patient is chewing with quadrant 1, I do the rest of the treatment. It was my pleasure watching Professor Yang and Dr. Son do the work on another level. Thank you. Thank you very much. Let me briefly summarize what you have said. All of you recommend staged approach, and Dr. Yang Seung-min talked about making bone first before placing implants. Dr. Son said implants will be placed a little bit deeper, close to the basal bone, and sufficient hard tissue will be obtained. Sinus graft and vertical augmentation can be done at the same time. And Dr. Park said we need to utilize the physiology of our body, so the vertical augmentation is to be avoided. Sinus bone graft can be done first, and for concave part treatment, implant prosthesis should be made supramargin. Today we talked about the placement depth of an implant and bone graft approaches. I hope this proves to be helpful when you encounter a similar case. I'd like to thank 3 doctors. Thank you very much. Regrettably, this is the last case discussion, which has been striving to give help to our clinicians. Thanks to the dentists who share the difficult cases with us, we could have discussions on how to solve the problems. It has been a precious time for all of us, and I also learned a lot from this discussion. I had a special privilege to work as a moderator, and this will go down as a precious memory for me, as it has been the representative program of Dan All. It is sad to say goodbye, especially Professor Yang Seung-min and Dr. Son Young-hui have been from the start of the case discussion. Would you give us the last remarks? It is my pleasure to have been encountering various clinical cases, and it has been a precious time for me to share a lot of information with many dentists. It is sad to end this program in Dan All, but I heard that Dan All is coming up with a better program, and I look forward to it. Thank you very much for watching us. I'm happy and sad at the same time, thinking our PD will no longer give us the SNS messages and try to talk to us. I don't know which emotion is stronger. At the beginning, I was not sure what I needed to prepare. By preparing the cases for the questions given to us, I studied a lot, and I'm thankful for that. I also look forward to another opportunity to be invited to a better program being devised by Daniel. Thank you very much. I would like to ask Dr. Park Jong-hyun to give us a word. He has been coming here all the way from Seosan every time. I never imagined I would be sitting here and do the discussion. It has been my honor to be able to meet Professor Yang Seung-min, Dr. Son Young-hui, Professor Kim Kyung-taek, and Professor Kim Kyung-won. We had a good discussion on surgery, from which I found solutions to my problems. I learned a lot from the 4 doctors, and I'd like to thank you very much. My gratitude to Dr. Kim Se-jin too for wonderful summarization. Professors, doctors, thank you. I would like to thank the audience who have been watching the case discussion. We'll come back to you at another opportunity with another program. I am Dr. Kim Se-jin. Thank you. Thank you very much. Thank you very much. What's your impression on closing this program? It is scary to produce the answer to some of the questions. There's no correct answer. And I feel sorry that I sounded like I'm providing the correct answer. And many people helped me and made me feel comfortable. I really enjoyed it very much during the filming. I feel both happy and sad at the same time. It was fun. I had a lot of fun. And it was my pleasure listening to other doctors' comments. And it is regrettable that I won't see you again. I would like to thank the viewers who listened to our cases and explanation. I didn't have a chance to get involved in a discussion program like this, and I would like to thank Dr. Kim Ki-sung, who introduced me to this program and gave me a lot of encouragement. And I would like to express my gratitude to Dr. Lee Kwang-hun, who has given me a lot of advices and help in preparing my cases for this program. So it has been like preparing for this program with Dr. Lee. Thank you. While I was trying to find the similar cases to the ones under discussion, I really learned a lot from the process. There has been some disagreements, but still we learned a lot from each other during the discussion. This has been an opportunity to look back on the cases I didn't pay attention to, and the reflection has been very helpful. It was very good for me because I could learn from the deep experiences of our doctors, and I hope I have another opportunity like this to come back and see you again. Thank you.